of the mini symposium of IHRS web series tonight. My heartfelt special thanks to Dr. Sanjay Dikshit for putting it along. It is all his hard work and vision, I would say, which is making us go to a new horizon with these web series. And he's done a fabulous job. Today's VT Symposium is actually one of the best I've ever come across. So I welcome Dr. Sanjay. And along with him, I have two wonderful people, Ajit and Deepak, to support him and take the proceedings forward. Over to you, Dr. Sanjay, Ajit, and Deepak.
Vanita, thank you for those very kind words. And yes, it is indeed a pleasure and a privilege to, do this session today, because on the panel here with me are some of my dearest friends, colleagues, and with John, even a mentor. So he fills all three categories. And so it's just great that, they're all here. And obviously we're very grateful that they've taken time out from their Saturday morning to do this for us. And for John, he's just an hour behind, so it's really early, and so it is for the rest of the group here. So thank you very much for doing this, and I hope the audience will really benefit from this interaction and the wonderful talks that we have lined up. So let me start by bringing on our first speaker, Dr. Elad Anter. Dr. Anter is currently endowed professor of medicine at the Cleveland Clinic. He's the associate director of the EP program there, and he also directs his own operations through this lab that he established, where he does a lot of the cutting edge work. Elad, was at Penn and is a dear friend. And after he graduated his fellowship, he moved to Boston, where he became the director of the cardiac EP program there, and did some really amazing work together with Mark Josephson, and then moved to the Cleveland Clinic last year. Elad's expertise is very wide, and his research interests are quite diverse. But some of the seminal work that he has done on, defining the VT circuit using high density mapping has really given us these unique insights into, how that arrhythmia sustains itself. And so it's wonderful that he's agreed to join us today, and his talk is going to focus on this seminal work that has really advanced our understanding. So Elad, if you can please take it from here.
Thank you, Sanjay. Can you hear me well?
Yes.
Okay, great. So thank you very much for the invitation. That's the first time that I present in the Indian HRS, and it's a true pleasure. And for next time, I don't mind waking up earlier if it's good for you. Okay, I know that it's late in India. It's a true pleasure to actually present with people that are good friends, mentors, and colleagues. I went to training with David Frankel. We all have been, indirectly mentored by John Miller, with his permission or not. But we enjoyed a lot of his insights and publications, and a lot of what I'm going to say today is related to John's work. And I remember a sentence that, I had conversations with Sanjay when I was a fellow, because Sanjay was actually when I was doing my fellowship, Sanjay was my mentor. I remember that Sanjay told me, and I'm not sure that you remember, you told me that you actually learned VT from Dushan. You remember that you told me that?
Yes.
Yeah. And I must say that, I feel the same. I think that, I learned VT, obviously the entire group, but Sanjay was my absolutely my mentor and taught me VT, and I'm very grateful to have you as my mentor and someone that invites me repeatedly to speak. So thank you. So I'm going to focus on, you gave me a lecture of high density mapping characterization of the VT circuit. So I'll try to make the best out of this, not necessarily focusing on the density part, but about the VT circuit, what we learned, what is actually new, and where should we go. So high density mapping, catheters for mapping any arrhythmias, VTs or or atrial arrhythmias, It's not a new thing. And we have been using non-roving catheters. If you look on this beautiful paper that was published in 1982 when Andy Wheat was a fellow with Moritz Alessi at the Netherlands. This is a beautiful study because back then in 1982, they didn't know if infarct-related VT is reentry or not. And they used a really high-resolution mapping catheter, maybe not as fancy and sexy as the one we use today, but this shower head device that has so many electrodes on it with very robust cabling was able to actually give us a very good understanding of what the mechanism is. As you can see on the left, this is the upper left side is just activation during sinus rhythm. What do you see here in this isochronal mapping? Activation slowing, right? What we call today isochronal crowding, right? 1982, we're still like, drinking milk from our moms when this was actually discovered. And if we put more and more extra stimulation at shorter coupling interval, we can actually get reentry. So high resolution mapping, isochronal crowding, all of these things is not new. That has been done before. John Miller, that modestly sitting in his home watching the Zoom now, like he have done high resolution mapping, high density mapping with a non-roving catheter in the operating room during VT. And we had this information to characterize the circuit back then. Natasha de Groot and Alessi use those more sophisticated printed circuits in the atria. I use the same thing in the ventricle in animals, but high resolution mapping or high density mapping is not a new thing. So when we come to kind of like assess what new things we have learned, we have to be cognizant to the point that, it has been described before. But nowadays, and I'm grateful for all of this catheter because it helped my career and it helped many of the fellows in my lab describe any of those catheters. From the pentarray to a more like sophisticated iteration of the pentarray called octarray and the Orion catheter. And now we have the grid catheters. Obviously we have the circular lasso. Another catheter that's very interesting is those, ablation catheters that incorporate very small electrodes on them, allowing you to see the near field local electrograms while you ablate. And obviously there is a new iteration of a big footprint of an ablation catheter. It's called Elad catheter that have tiny microelectrodes on this too. So we have many more of these catheters that are roving, meaning that we can actually use them percutaneously and move them in the chamber and collect points. But you also have to be careful that a lot of this is not in the service of understanding more physiology or ablating more, but it's in the interest of marketing and hype. And one example like this would be omnipolar mapping with a grid catheter. So I think it's a good idea. And omnipolar mapping means that, instead of just acquiring, making bipolar electrograms from unipolar along a spline, if it's an ablation catheter, M1 and M2, if it's a pentarray, so like, the electrodes along a single spline, because you have a fixed grid here, you can make electrograms not only along, but also across. So if you have a wavefront that comes from a specific location, the voltage map that you're going to get is not going to be impacted by the wavefront, but you're going to see the highest voltage. So you're not going to miss areas of surviving myocardial bundles. And this is true. That actually has been proposed by Jacques de Backer and Madison Spack, 40 years ago, the idea of omnipolar potentials mapping. The issue is that nowadays we move the catheter. So the catheter moves from 90 degrees to 180 degrees. So you cover actually the same area at multiple footprints of the catheter. So here I show you an example of mapping in the atria, different voltage maps with different activation direction. This is with pacing from the SVC, this is from the tricuspid annulus, from the IVC or from the septum. And you can see the voltage maps are different. But if you collect more than 1 or 2 points and actually you move the catheters, all the maps looks the same. Okay, so you have to understand the utilities of high resolution mapping, but you also have to acknowledge, you know, what really new and meaningful data it brings. So what determines mapping resolution? So obviously the electrode size, as the electrode is smaller, you have more, you know, you have a higher fidelity recording. If the spacing is shorter, so you sample from a smaller area, so you increase the resolution or you reduce the size of your pixel if you want to see this way. The catheter design, if you have an ablation catheter that is most of the time in perpendicular orientation to the surface, you basically just mapping with M1, and M2 is the same like M1. However, if you have a penta or a grid, so both electrodes are on the surface, so you have, you know, you have different different mapping, different algorithm, different EGMs. The type and the location of the indifferent unipolar reference electrode, that makes a big difference. If it's in the IVC, you may not be able to subtract all the far field because, you know, the far field can be sensed on the two electrodes, M1 and M2. So you're not going to remove them. However, if you have an indifferent electrode that is a little bit more local, you may have a better way to look on far field, near field in areas like ventricle. The type of the instrumental amplifiers, you know, you probably have seen, you have very high resolution mapping catheters, but on the Pruka, it may look not that great because the amplifiers don't have the ability to deal with the impedance or the resistance that comes from those electrodes into the surface. And most importantly, the optimal mapping resolution is unknown. We don't really know what we're looking. It doesn't mean that the smaller is better. And it may be determined by the specific substrate. It could be that what you need in the ventricle, which in my mind is around the resolution of a millimeter, millimeter and a half, more than this doesn't really give you more, you know, useful information, but it may be not enough for the atria when you may be looking on a micron level, or maybe not, but that needs to be determined. Before I go to the VT part, I just want to spend like 1 more minute here and just show you, like, you know, more illustrate those principles to you. So what is the impact of electrode spacing on electrogram? So if we have a wavefront coming, you know, in this direction, this is the red arrow, and the block here is, you know, is the tissue that it's recording from. So obviously, if you look on the unipolar electrogram of the distal, you know, this is how it looks like. The unipolar of the proximal is going to be delayed because it occurs at the later time. And you're going to have something that looks like, you know, a fractionated double potential, or even late potential. Now, if you start to progressively move the proximal electrode closer to the distal, so you shorten the interelectrode spacing, so the unipolar electrogram of the proximal become, you know, much closer in time to the distal. And now you have, like, instead of separate potentials, you have like an M-shaped or so. And if they're really close, you actually have a normal electrogram. Okay, you have a normal electrogram. And what happens if you make them really, really small? Like nowadays, we have already 100, 150 microns. Then you start to have the same thing that you see here, but at a lower amplitude. Why the amplitude is going to be smaller? Because you have more cancellation. You cancel, they occur at the same time, right? If you make the electrodes so small, so close to one another, so the activation is going to occur at the same time, and you have a much bigger cancellation effect. This is for the pen people, you know, that's like for, I wish Frank was here, but, you know, the idea is that, you know, if you have a bigger electrode, you may have a bigger far field. So you can record things that happens like away from you, and that's true. Unipolar voltage or electrogram show you information beyond like the local vicinity of the electrode itself, of the tissue itself. However, one thing to remember is that it doesn't change the thickness. You don't see deeper. What you see, you just see kind of like, you know, a bigger radius, if you will. And we have a lot of modeling on this. The electrograms become wider, but as far as like the field of view, you don't really change it. What you're able to see is around 4 millimeters or so. And this is the point I want to make about pentarray versus thermocool, or like, grids, something, catheters that actually are both electrodes are on the surface versus, in ablation catheter where usually the proximal electrode is perpendicular to the tissue. So what happens is that M1, it always looks the same. This is the red electrogram. It's always going to look the same. But what happens is that as you become from parallel to the tissue to perpendicular to the tissue, M2 become flat to disappear. So basically what you get is more like a unipolar electrogram. Okay, and I think many times that's the difference between the what we say high resolution with pentarray. I don't know, after we publish these papers and like this, I kind of like wonder like why it's not that simple. Why is it high resolution? Like if you have an electrogram, if you have a surviving myocardial bundle there, why like a bigger electrode is not going to detect it? I think it does, but in many ways it has to do with this, the relationship between M1 and M2 and how they're being canceled. And this is to make this point. Okay, but I'm not here to talk about resolution, but it's mostly about VT. So this is one of the examples that we had when we wrote the paper about comparing pentarray to thermocool in the ventricle. This is animal model of healed anterior wall infarction, and you can see dense map with what looks to be homogeneous scar with thermocool, showing you a channel of a higher voltage with the pentarray, and this channel just happened to be an area of diastolic pathway. So that was nice because it showed us that maybe not what we think is dead may not be dead, and it could be some electrograms behind it. I like to show this example because this illustrates the point of small electrodes for mapping areas of heterogeneous scar. So this catheter is actually an 8mm catheter that have those microelectrodes on it, called like the MiFi catheter. Now in this case, we mapped already. It's fast VT, but we were able to map fairly quickly, like the VT with the Orion catheter. This is the VT, and now we put the the MiFi catheter just about to ablate. And I want to show you. So MiFi 1-2 is basically M1, M2. Okay, this is M1, M2 that you see. MiFi, those in blue ones, those are the microelectrodes, and their gain the same. Okay, the gain is the same between them. So you can see how you can get those near field in the isthmus that looks like very low amplitude in the with the M1, M2. And I think that's kind of like the gestalt of like, why, smaller electrodes, and especially if both of them are touching the tissue, can give you more information than M1, M2. So what did we learn from high resolution mapping of the circuit? We learned that we can make beautiful maps, okay? And I think like many years ago, we were like very excited that we can make those maps, but this excitement, for me at least, has worn off. Because the question is that apart from like having those pictures, does this actually help us? Mostly because most of those VTs are not tolerated, and we cherry pick like relatively slow VTs to show. But does this really provide us information or those technologies that can help us beyond what Sanjay and I did in 2010? Okay. So what did we learn from this? So we learned that multiple VTs originate from a relatively small region, and we showed this in 2015 or 16, that you have an encore, you have an area that serves as an encore for multiple VT configurations cycling in the same heart. I thought like, wow, it's great. Like I was so euphoric for like a few days until I had actually time to look in the literature and see that everything was published before by John and Mark, by Chachio and Andy Witt. Everything has been published before. Yes, not so sexy with the movie catheter and not like on Twitter, and people, didn't really read it so much, but everything was there before. But it still, is it useful information? It is useful information. We also found that the area of maximal activation slowing during sinus rhythm, this is this area that services the encore, and simultaneously with our data in animal, Rotang has done, actually I'll show his data in a second, beautiful work on this as well. But this is to illustrate the point. This is a patient that underwent 4 different ablations. You have huge anterior wall infarction with aneurysm. This is the area of slowing. This is the activation during sinus rhythm. I guess you had like a right bundle branch block, and this is the VT. Okay, so the VT is localized in an area of fixed block. Okay, so that's nice because you can, and as this patient I still see him virtually. I saw him last month at the Cleveland Clinic, and he's still doing really well. And the ablation was limited only to this area, so it's helpful. And Rod is there's that beautiful work in several publications showing the same phenomena with the St. Jude system and with duodeca catheter, and he showed that you can, with relatively limited ablation, get overall good result. The 70% here is including ischemic and non-ischemic patients, so it's not bad at all. So with this concept, we actually were so excited to start the Physio-VT trial that basically was a prospective multi-center, non-randomized but controlled study, ablating only area of activation slowing during sinus rhythm. But after the first few cases, I realized that either something is wrong, or that the concept is just not true, because patient kept coming back with arrhythmia after they had like limited ablation. And I saw in my mind Luigi and Andrea laughing at me at conferences, and I needed to do something before I can present this data. So what we did was decided, let's just do the mapping during activation from different directions. This is like an involved study because you don't want to keep the patient on the table for so long, but I needed to do it. So we mapped them doing sinus rhythm or atrial pacing, RV pacing, LV pacing, either using a second catheter, retrograde or septal, or from a CS lead or a branch. And what we found was that the area of maximal activation slowing is going always to be the area that the wavefront first approaches the infarct. So here you go. So what you thought would be like just, the area of slowing during sinus rhythm may not be the case. And I want to illustrate one example to you. So this is sinus voltage map. This is sinus activation map. No slowing. SCAR, no slowing. But here you see a VT isthmus. You have the whole circuit. I showed this to you before. Now, you want to look on this electrogram and see what happens. So I'll show it to you. So here, instead of mapping at 80 beats per minute, we mapped it 120 beats per minute, just like quickly, as quicker as we can, just like to get information there. And you can see that at 120 beats per minute, all of a sudden you see slowing. So the slowing is rate dependent, like in the AV node. You're not going to show a slow pathway if you are, if you just like a normal sinus rhythm. And if you pace from the LV, similarly, you're going to have an area of slowing. So and that goes back again to a work that has been published many years ago already by, this is from Janssen and Alessi, that's showing that activation slowing or block is determined by the cycle length and the wavefront. So the VT subset is partially functional, it's frequency dependent and it's direction dependent. And in some way, I like the sentence that Al Buxton actually gave me. And he said, you need to stretch the electrical system like we do for the AV node. And I think it's true because VT doesn't occur during sinus rhythm. It occurs like something happens. Usually you have a premature beats that come from somewhere else. Okay. Now, and you all know this, right? Like this is not so surprising. Like, during sinus rhythm, you may have something look like fairly normal, maybe a little of a lava, and all of a sudden you pace and it's become like a late potential. And this late potential can become the isthmus of your VT, but you could not recognize it in sinus. What other things we discovered, and I want to say discovered, I don't want to include myself here. I did the work, but actually Mark discovered this. Because I thought I came to him and said, like, wow, look, it's beautiful multiple circuit configurations. And what he really liked about it, after we looked on the electrograms, is that he said, Elad, look at this. The barriers, what you think are barriers of the isthmus, are not really barriers. There is actually slow conduction through them. They're actually, during the VT itself, there is transverse conduction through those barriers. The issue is that this transverse conduction is so slow that it protects in some way the orthodromic wavefront through the isthmus. The other thing that he said was, and I see this, that is true more and more, is that don't look on this big circuit here, big isthmus, coming from in below and spreading like a figure of 8 here. The critical area that you have are those little little turnaround points. These are the turnaround points. If you don't have this slowing and these turnaround points, you're not going to have VT. And these are the electrograms from there. Like, this is not noise. You have electrograms here. You have an electrogram here, very fractionated around here, like basically from the isthmus to, to the beginning of the QRS, from the mid-diastole to the beginning of the QRS, and also at the end systole, and all within, like 2 millimeters apart. This is the distance between these electrodes. Now, what does this mean? And actually, one thing is that if you look here, conduction in the isthmus itself is fairly rapid. Boom, it goes very quickly. Now, it could be it goes quickly because it's coming from a deeper layer. What I don't know what people call today 3D. Of course, everything is 3D, or that because it's really fast and the conduction slowing is in the curvatures. So if I show you this and I ask all of you which electrogram you would think would be the best electrogram to ablate and terminate this VT, I bet that most of you are going to say B. If let's say all of them entrained and all of them concealed and all of them have the same PPI that is similar to the tachycardia cycling, and that was the case here. You would think that this one would be the best to ablate, and I'll tell you that's actually not going to be the best to ablate. We did ablate here. You just change it and you get a different VT. It's this one that will be the best to ablate, D. Why D? You would choose, I would choose A, B, or C, because D is this turnaround point. Luckily, we had the mapping to know where the turnaround point is. You can see here, very long potential here, and then very, very long potential here. So this is the machinery. This is the anchor of where things happen. The isthmus is fine, but it's rapid conduction there, but this is what provides you the slowing to allow the reentry to continue. Another observation, and I'm about to finish here, Sanjay, is that entrainment is very helpful, and I advocate doing this and resetting too. It helps us understand the physiology of a circuit and so forth. But you have to be really careful where you have PPIs that are relatively similar to the tachycardia cycle length in an exit site, because you can be miles away from the circuit. You can be really away from the circuit and get concealed entrainment and a PPI that is maybe plus 10 or plus 20 more. Why is that? Because once you pass this turnaround point, you have very rapid conduction. So if you are pacing from this, you are like in the same stream of the wavefront that comes out. So you are going to be concealed, and the PPI is going to be just as longer as as this rapid conduction at the exit. So, and we define it as like a pseudo exit. Okay, so you have to be careful from this. Lastly, and that's kind of like to maybe like it will be transitioning to Saman's talk soon, is that I'm not that enthusiastic about electroanatomical mapping in general, or about the future of them for mapping therapy for arrhythmia, because what really we see is the surface. We are able to see 1 or 2 millimeters from the surface. So this is an example of a left circumflex infarction, healed infarction in a swine. You have, one of the highest resolution mapping catheter, not even yet on the market. It's called the Octaray. Completely normal bipolar, completely normal unipolar, high density map. Look on this LGE map. You have a millimeter of healthy subendocardial tissue. All the rest is transmural fibrosis, and this is the corresponding histology. This is a work with with Reza Nazafat that I collaborate a lot, and hopefully we'll move to the Cleveland clinics too. But anyway, this is like it just shows you the limitation of all those mapping systems. And I think you have to acknowledge this, that many of the circuits that we are dealing with are mid-myocardial. So the endocardium is kind of like fairly normal, maybe a tiny bit abnormal, but not too bad. Epi is normal, but all the slowing and all the substrate is in the middle. You can't see this. You need imaging to see this. I'll end here and I'll say like high resolution mapping technologies provide an opportunity to examine the substrate at greater detail. However, the use has not yet translated into improved clinical outcomes. Nice pictures are not enough. We need better clinical outcomes. And this may be related to ongoing efforts to examine the same surrogates at high resolution instead of using high resolution technologies for discovering new and potentially more specific surrogates. And I'll end here. Thank you.
Elad, that was terrific. And I'm sure there's so much for us to digest, and perhaps the questions will be generated as people imbibe all this information that you've given us. So if it's okay with you, we could potentially save the questions for the panel discussion where we can have a more extended conversation. And I would encourage the audience to, please send your questions, as well as the panelists, which are the faculty, will also, quiz each other. So I'm really looking forward to that, Elad. I have a few questions that I'll save for the panel discussion, but I'm going to move on to our next speaker, Dr. John Miller. You've heard his name a few times here. John is, if the Penn EP original group was the Fab Four, then John to me is the George Harrison of that group, because he's the most thoughtful person that I have really ever encountered, and some of the concepts that he participated in developing with Mark Josephson still continue to drive a lot of our understanding of ventricular tachycardia. John is also, amongst many things, a very accomplished artist. And for those of you who don't know this, some of the original pictures in Mark Josephson books are actually all designed by Dr. Miller, using, I guess, just regular art, and then he's moved on to more sophisticated computer enhancements, but he's just multi-talented. And I'm so grateful that he's here with us today to share with us his insights on really understanding the VT circuit. And the topic that I felt was most appropriate for his level of understanding is whether entrainment still remains the gold standard for characterizing the circuit, especially now that we have the tools that Elad just shared with us. So John, love to hear your thoughts about what Elad presented versus what I think is the gold standard, which is entrainment.
Very good. Well, thank you, Professor Dixit and Dr. Rohr, Dr. Likwandala, and dear friends. Appreciate this opportunity to be with you today. This is my topic, and I feel pretty passionate about it. Can you see my screen fine here?
Yes, we can, John.
Okay, so entrainment, as we all know, is a dual purpose tool. It has two important functions for us. First, I mean, we have to nail down that this is reentry, first and foremost. And there'll be times when, especially if you have incessant VT, it could be a focus, it could be reentry, and you need to nail this down one way or another. So it can help us determine mechanism, whether reentry is or is not present. And of course, the fundamental feature distinguishing reentry is the presence of fusion. Having passed that and determined that we do have a reentrant arrhythmia, it can help us select appropriate ablation sites in ventricular tachycardia as its relationship to the VT circuit itself, pace matching with tachycardia, exact matching versus fusion, inside or outside of a circuit. The all-important post-pacing interval, the highly vaunted but flawed post-pacing interval in comparison to the tachycardia cycle length. We'll talk about that a little bit. And the stimulus to QRS interval in its relationship to the electrogram to QRS interval during the tachycardia. And importantly, entrainment is really the only technique that I know of, stimulation during tachycardia, to be able to exclude a site as being involved in the circuit of these little bystander sites where we can waste a lot of time because they look very juicy. So it can be used to validate putative candidate ablation sites. And of course, the hallmark of entrainment is fusion. And here's a cartoon from my early days of this putative figure of 8 circuit, and we're recording and going to be stimulating from out here somewhere. So the electrogram occurs late during the QRS complex. And when we stimulate there during sinus rhythm, we get a completely different looking QRS complex, a completely different looking wavefront if we do isochronal mapping, because it goes into the circuit and overwhelms the exit, so it looks like fully paced. When you do these together, you end up with a blend of the two, because we're driving through the circuit and exiting from it to a degree, but also having this boundary that's set up over here where we have influence from the paced wavefront, influence from the tachycardia, and so we have this fixed fusion, this beautiful fixed fusion. That concept can be used to interrogate further and decide whether the pacing site is in or outside the circuit. This is a so-called remote site here. where we again are recording from way out here and stimulating from here. When we paste from there, and the last paced wavefront comes around, it goes through the circuit, it goes back around to the circuit, but comes way out here. Then we have our first VT beat come back with a post-pacing interval way off to here that is in excess of the tachycardia cycle length by an amount that is reference to the distance from the circuit. If we pace from a slightly different area here in this region, recording from here, pacing from here, you end up with a situation in which this is actually part of the circuit. It's an outer loop, but because it is fused, it's not within the diastolic corridor. You have fusion of the surface QRS, but a post-pacing interval that equals tachycardia cycling. So it's in the circuit, but not in the diastolic corridor. And finally, when you move the catheter into the diastolic corridor, we have this beautiful concealed fusion, this mid-diastolic electrogram. We're pacing from here and recording tissue that's on the outside of this as well, where you might have an outer loop. And so post-pacing interval is perfect. We have entrainment with concealed fusion of very fine potential ablation sites. And when it all works out for you, here's this nice mid-diastolic electrogram. There's diastole shaded in yellow. The electrogram from here to the QRS complex is 180 milliseconds. The stimulus to QRS, just about that. And when we look at the post-pacing interval versus tachycardia cycling, they're right on. Ablate here, and it goes away in just a few seconds. So that's great, but there are some problems with the whole concept of entrainment. Like all tools, it has to be used appropriately and correctly in order to get the right answer. And even when you do everything right, it doesn't always work out well. A very common thing I see in my lab is non-capture with pacing. You get some really great looking pace matches when you never capture, because of course it's all VT the whole time. And you don't want to pace a too high output, because then you have some non-specific findings here. Pacing from too close to a circuit to be able to show fusion. These are in the diagnostic realm, not pacing for long enough to entrain, and pacing too close to the exit, so you can't see fusion, even if it's there. In the validation realm, if you pace it too high output, you're going to be capturing more tissue than you actually want to, and have some non-specific results. We'll come back to this non-propagated stimulation business towards the end here. You might change the tachycardia into a new morphology, terminate the tachycardia. That's no fun. Many sites might meet your criteria for being in the circuit because you're in a broad band, like cavo-tricuspid isthmus reentry. In the atrium, or very broad band, a lot of tissues involved in it. You might find the nose sites meet your satisfactory criteria because of its a long post-pacing interval, no matter where you are. And this could be because of so-called decremental conduction within the circuit. It's not very commonly seen in my experience, but that it causes a whole lot of a problem, but it certainly can occur. And then far field capture, as we're doing up here with too high output, and you have a post-pacing interval is too short. So there are all kinds of problems with the post-pacing interval. Everybody really leans the shoulder into it very hard, and that it's great when you do it right, and it's not so great when you don't do it right. Here's an example that my fellows love to do this. How we did it, we paced during tachycardia, we turned it off, and here we are. It looks perfect. And the problem is this never actually captured here, because our stimulus artifact can be seen moving throughout the QRS complex. Now, it may be that you didn't pace at high enough output. It may be that if you just paced for another 2 or 3 seconds, you would have caught up with things and had nice entrainment. We don't know. This doesn't count. This didn't ever happen. And to make inferences about this post-pacing interval here, it's completely fallacious. It just doesn't do you any good at all. Now, there are situations in which you can't use entrainment at all if the tachycardia is grossly irregular. Now, you can get a post-pacing interval. You can always measure that, but you don't know what tachycardia cycle length to reference it to. So interpreting where that is in the circuit is very difficult under those circumstances. If the tachycardia is not sustained, you can't apply it. If it's poorly tolerated, you can't apply it very much. And you really can't apply it if you can't have any tachycardia at all. You have to rely on substrate mapping. So these are situations where entrainment is just not available as a tool. So what would be the ideal tool? It would be something in which we can get answers very quickly. It's relatively easy to use. You don't need any special equipment. It's universally applicable in all cases. very sensitive, very specific, and very reliable. There's no asterisk that says, yes, but you didn't do this right. So how does entrainment stack up with this? Well, it gives you your answers reasonably quickly if you are pretty careful about where you do the entrainment. You don't want to do it just anywhere in the ventricle. You want to focus in on a spot that looks pretty good, and it can give you an answer pretty quickly. It's pretty easy to use, not perfect. You don't need any special equipment. You need a stimulator. Everybody's got that, and a catheter in your hand and some recording equipment. It's not universally applicable, as I said, because you have to have tachycardia that's reasonably well tolerated. It's pretty sensitive. It is very specific. I don't know that there are tools that are much better than this, and it's pretty reliable if you use it correctly. Well, let's look at Dr. Anter's stuff here. How about high density activation mapping? It gives answers pretty quickly with like the Orion catheter. You can get a lot of information very quickly. It's pretty easy to use. I think I don't actually have it because it's special equipment that's needed, and my hospital doesn't think I need it. So that doesn't help me a whole lot. It's not universally applicable because I don't have it. I can't use it. It's rather sensitive. It's not so specific because it gives you activation wavefront, and you can see all kinds of little vortices. In fact, he shows this beautiful one with this long diastolic corridor, and it seems like a little rotation going down in the lower right-hand corner, like it might be a little rotor down there. And you can ablate there, and not much happens because that's not where the action is, and it's pretty reliable. Well, how about other things? How about single extra stimuli? My buddy Dave Collins, he's onto this thing, and it's better than entrainment in some ways because you're not, obviously it doesn't take as long because you're giving a single extra stimulus as opposed to a whole train of stimuli. It's less likely to disrupt a circuit. It's less likely to terminate or fibrillate somebody. So why not do this? And it gives answers pretty quickly. It's pretty easy to use. You still don't need any special equipment. You can use it in most instances, unless the tachycardia is not tolerated. It's pretty, not very sensitive though, but you have to sample a lot of different sites. Rather specific if it gives you the answers you want, and pretty reliable. But it's got wrinkles, just like everything else. So here's a situation where I'm giving a single extra stimulus during a tachycardia at this nice diastolic electrogram here. And that's the green is a VT beat that's superimposed. It's a perfect match here. And the electrogram to QRS during tachycardia is 245. The stimulus to QRS is much shorter here. So we're capturing more tissue than we want to. We might reject this site as being unimportant. The post-spacing interval, on the other hand, is pretty good. This is pretty funny stuff going on in this circuit here. So it's getting getting out to the exit sooner than we think, but it's going through an inner loop in an okay fashion. Pretty interesting stuff. So I'm not sure how I would interpret this site. I know what happened in this guy. He did really well when we ablated at that site. But here we're talking about far field capture, and it's a non-specific result. Really can't interpret this too well. How about this case here? Here's this nice diastolic electrogram here. Here's the paste VT complex superimposed on the paste complex. You see this very long stimulus to QRS interval here. It's perfect match as well. The electrogram to QRS there, 115. The electrogram to QRS here, 230. Very much longer. Post-spacing interval, very much longer than tachycardia cycle length. So you say, okay, I know I got this one. This is a bystander site. Meets all the criteria for bystander site. We kept stimulating at that site, single extra stimuli, and this is what happens. Well, this is not a bystander site. This is a perfect site because we have termination without propagation. And I want to spend a little bit of time on this concept here. This is where I see it the most common. We're trying to entrain the tachycardia. We got this beautiful mid-diastolic electrogram, trying to entrain, and all of a sudden we see a blank. There's nothing happening. And then you pick up with QRS complexes that don't look like anything like what you're aiming for. Well, I thought this is a great site. I should be seeing entrainment with concealed fusion. Instead, I see junk, and it terminates. So you have to start it up again, move the catheter to another site. This is a terrible site, when in fact it's a perfect site if you know what you're looking for. So this is a phenomenon here. Here's our figure of 8 circuit. We've got these fixed or functional barriers during VT. Here's our diastolic corridor here with reasonably rapid conduction. If you put in a stimulus at just the right timing and just the right location, it tries to propagate outwards, but it can't because it's still refractory from the prior beat. It can't go north or south because of these either fixed or functional barriers. And the next beat, this tissue is still refractory from, or the next beat is coming in here. So the impulse dies right there without propagation to the rest of the heart. And you can't do that anywhere else. This is a beautiful tool. And if you continue pacing there and the site is really reasonably close to the entrance to the diastolic corridor, it's electrically closer to the entrance than the exit, you'll get a QRS that doesn't look very good at all. It reverses the propagation. You think it's a terrible site. If, on the other hand, your site of stimulation just by chance is closer to the exit electrically, you'll end up with preservation of propagation. It'll look exactly like your tachycardia at the exit. So suspect that you have this phenomenon going on when you're pacing at a site that looks like it should be pretty good and give entrainment with concealed fusion, but you have this unanticipated pause in the midst of pacing, as I showed on that previous slide. You have a major change in the pace QRS complex when you finally look up and see what you're doing, change to a different morphology after you've stopped pacing, or a termination to sinus after stopping pacing. But the single extra stimuli removes all that confusion because you're only looking at the effect of the single extra stimulus, not some train that you're trying to see what happens at the end of it and missed what happened at the beginning. So how does this work here? This signifies that while you may have a relatively large circuit, there is a small portion that is a real bottleneck. And not all circuits have this, but many of them do. And so it's a small amount of tissue that's eminently critical for the perpetuation of the VT. It's very superficial because your catheter is able to affect it with a stimulus. You don't have a very large field of effect of the stimulation. And the catheter tip is right there. If you're a few millimeters away, it's not going to have this effect. So it's a really good tool to use. Our experience with this is it's not terribly expensive, but we have some. And why is this not going on? Okay. I have, that I know of, collected 28 patients over the last few years. Age range is about the same as everybody else's. Most of these are coronary. There are a few cardiomyopathies in here. When we found this phenomenon, if you ablate at that site, VT goes away within about 4 seconds or so. On average, there's quite a range, but many of them are like the next beat, it's gone. Still not a perfect tool, though. It's very specific, extraordinarily specific, but it's not very sensitive. You may not even have such a site in that VT. It may be a relatively broad band, and yeah, you'll have a good ablation site, but you can't, the field of effect of the stimulation, it's able to circumvent it, so you can't have that termination in the middle of it. So let's look at this tool here. Does it give answers quickly? Well, if you're targeting where you're going, it's reasonably good. You can't just do this all over the place. You have to do diastolic signals and say, is this going to work? Is it not going to work? Pretty easy to use. Even people with a small attention span can look at one beat and do pretty well. You don't need any special equipment. It's not universally applicable because you got to have VT that lasts long enough to do this. Not very sensitive, but is extraordinarily specific and quite reliable. I don't think I've seen this fail me before. But that's not the tool I want. I don't think that's the very best tool. The tool I want is this tool. This is a mega catheter here. You see all these electrodes. There's about 400 electrodes, maybe 1,000, I don't know. Each can stimulate and each can cool the tissue very quickly. I don't know the Peltier effect is able to do this or not, but what I would like to do would be able to reversibly interrogate a bunch of different sites in here and say, okay, is this involved? Is that involved? Is that involved? Is that involved? Now, again, you have to have a sustained tachycardia and you have to have contact with these things and so forth. So this is a little bit of a pipe dream, but it's, I think this would be a fantastic tool to really tell what is essential in all this. So I think that with all its foibles and shortcomings, entrainment remains the best way to characterize the VT circuit. It complements activation mapping. It's not. I think you can do this without without even doing activation mapping. If you know where to look from the surface ECG, put a catheter there, find a diastolic electrogram, and pace, you don't even really need activation mapping. We know this from way back. It's probably more specific than most forms of substrate mapping. I think that's pretty clear. You have to wait a little bit more with substrate mapping than you would with this. It can exclude bystander sites from consideration as ablation targets, and don't waste your time with those. It's not dangerous to do that. It's not bad, but it's not helpful either. And though it's not as elegant as single extrastimuli that terminate VT without propagation, it provides the same information, including in cases in which that's just not going to happen, no matter how clever you are with your catheter placement and coupling intervals. Then until something much better comes along, entrainment remains, as from my money, the best tool for characterizing the VT circuit in order to maximize the efficiency of ablation. And after all, everybody loves entrainment. Thank you for your time.
Thank you, John. That was terrific. And since you finished within the 20-minute period, we have time for a few questions. I'm sure the audience is just waiting to jump in. But while some of the questions are coming, the one thing that I struggled with when I saw Elad's work with high density mapping, it was in some ways actually an eye-opener, was this zone of slow conduction is how we conceptualize the isthmus. And if you look at Elad's movies, and I think he made that point again, that really may not be the case, that the turnaround points are where the slowing happens. But yet in the isthmus, it's not uncommon to find these really long duration electrograms. So how do you resolve that in context of what the electrogram looks like versus what high density mapping has shown us? Any insights on that?
Elad, are you talking?
Sorry, is the question for me or for John?
For both of you, because it's, I mean, John challenged you with, your tools versus his tools. So you can answer.
Okay, so I'll start. I think it's a complex situation, and every circuit looks different. And there are circuits where they're very small, so like you actually don't really have like a true like channel, but it's really like just an area of slowing that goes almost like a big rotor or a big like circle. So in this area, like you are going to find very long potentials, which are also those long potentials. If they're really part of the circuit, they represent the isthmus, and the isthmus can be just slowly conducting there. What I was referring when I showed, most times what you find in those big infarct-related circuits are like those very relatively long corridors. In those long corridors, they're relatively high frequency, mid-diastolic, short potentials. They typically happens when you have a relatively wide corridors, and in this area, ablation there may terminate this VT that you are dealing with, but you leave all the machinery still there for other circuits to develop. I think if you do find like a long potential that is truly part of the circuit, it's not a bystander, it's probably a better potential. This is my experience. The other point is that the termination without propagation. Many times when you want to entrain, so now and then I'll challenge you, John, here, like, because I really think that it's helpful to see the activation if you can. Because if you can, what will happen is that if you entrain from the middle of this corridor, you'll get like, very nice return cycles, and everything is going to look perfect. When you're trying to overdrive pace from those curvatures, hardly ever you're going to actually capture. If you are going to capture, many times it's going to be antidromic capture, and many times you're going to terminate without propagation. So I think it does goes along with with what you say. I think that your observation is absolutely right, but I think it does give you another layer of information.
Yeah. Well, speaking of layers, I think back to Sanjay's very insightful original question, these prolonged electrograms, I think, are composite recordings. I think, and I don't have hard evidence on this, but I know in some instances that there is an isolated diastolic potential that's buried within the rest of an electrogram from other layers, or you're recording from such a large area of tissue that you're recording from some stuff on the other side of the corridor barrier. And we see all these questions on the boards all the time. Which should you measure the post-pacing interval to? Which electrogram are you actually capturing? And there's some that are driven by your stimulation that occur before the next QRS before the next stimulation artifact. Obviously, they're not captured; they're driven. But that's part of the electrogram that you're recording. So buried within there is this diastolic electrogram, and I have some figures from way back in the OR days where it was clear that we were recording from multiple planes with this multipolar electrode array. And so you see a wavefront that's going one direction and a wavefront that's going in another direction. And these are sick. This is sick tissue. It can't be going twice on the same cycle. So you're recording different layers of tissue in there. And I don't know what our depth resolution was with those things. I know with the endocardial resection stuff that we did, you could record, through the 2 or 3 millimeters of endocardial scar, some stuff underneath. It was kind of filtered by the tissue itself, but the very superficial sharp stuff was what we were seeing, what we were capturing with the stimulation.
It's very helpful, John. There are a couple of really interesting questions that I think we'll save for the panel discussion that have come from some of our panelists. So we'll move on now to our third speaker, Dr. Saman Nazarian. Dr. Nazarian is a dear friend, and his training has taken him through some really top-notch programs. He spent time in Boston at the Brigham. He did some work at the UCLA, and then went on to complete his EP training at Johns Hopkins, where he then subsequently became faculty. And we were just very, very fortunate that we were able to bring him to Penn. And we have his wife to thank for that, because she came to us first. And then, as always is the case, the other spouse followed. But that worked out great. And Saman has really built for us this very unique portfolio through his expertise in advanced imaging, which we now use whenever possible during our VT ablation procedures. And so I'm very grateful that he's agreed to first participate in this forum, and then agreed to talk on some of the work that he has done on the role of advanced imaging to enhance VT ablation. Saman.
Thank you so much, Sanjay, for that kind introduction, and for inviting me to be in this forum. Two tough talks to follow. So I'll be talking about using cardiac MR mostly, and some CT imaging to really just augment our procedures. I wanna underscore that when I do a VT ablation, I don't just depend on the imaging. I think that the principles that John talked about and the tools that and principles that Elad mentioned are extremely important, and I would not replace them with imaging. So here's some of my disclosures. So how do we use MR imaging for identifying the substrates? I think that most folks are familiar with this, but just in case you're not familiar, just a brief overview. So when we obtain an MR image, we inject contrast, and let's see, if we start imaging right after the contrast injection, you select an image plane that contains the ventricles, and you can see the contrast starting here to come into view and highlight the right ventricle. And as you progress with imaging, you see some contrast entering the left ventricle. Image again very quickly, and you can see it start to brighten the myocardium. And there are certain parts of the myocardium that you can see are darker. So the contrast is not getting into those as much. And so you already, with immediate imaging within a minute, are getting a sense of which parts are less perfused and which parts are appropriately perfused. Even the resolution is getting high enough where you can see parts within the papillary muscle that may not be getting perfused as well. And you wait long enough, that difference becomes more accentuated. So this is used for assessing ischemia, but it's also useful for us, I think, as we learn that late gadolinium enhancement, which I'll show you in a second, isn't necessarily showing us just fibrosis. There are other processes that cause contrast uptake. So then that's within a minute. Now, if we wait more than 5 minutes an image, now we see what we call late gadolinium enhancement, where the contrast has, as you can see in the pharmacokinetic curves above, washed out of the normal myocardium in black and stayed in the abnormal myocardium. I'm going to call it abnormal myocardium. It's not necessarily scar, and I want to emphasize that this stuff could be inflammation, it could be fat deposition, and it could be scar. It could also, in some cases where we're really looking hard to see something, be just the fibrotic valvular structure extending into the myocardium. The specificity is not super high, and you have to always take that into account, that some normal tissue will enhance as you get closer and closer to the valve because of that fibrotic structure of the valve extending into the muscle. So early on, when we realized this capability, we wanted to take our electrogram points that we had touched inside the myocardium, and this figure now from, I think, 2010 era puts me to shame when I follow a talk by Elad, because you can see this is the way we used to touch the myocardium, with 1 point at a time. I still find it to be useful compared to some high density catheters, just because of the obviously because of the ticklishness of these catheters and how many extra beats and PVCs they cause. And so anyhow, this is what we took. We took electrograms, we took their XYZ coordinates in space, and we registered them to the images. And this, you can imagine, is quite a lot of work. You want to make sure as best as you can to register these images, align them properly. And then once we did that, we would take the data. And here I want to point out that more and more of this kind of work is being done, and you really have to take care to do the right analysis. And I'm just showing you this as an example of Simpson's paradox, which is what comes into play when you have data from multiple people and you pull it together, and you have, say, this person, patient 1, up here, and patient 2 down here. I think you can see my arrow, hopefully. And you do a regression with pooled analysis, and you get a line like this. And that's not reality, right? That's not reality, because if you actually do separate regressions that are clustered, what you see is that you would have had 2 regressions like this. And so when you do modeling in multiple patients with pooled data, whether it's from electrograms or whatever it is, I think it's exceedingly important to do this kind of clustered analysis. And so we took this methodology and looked at our data. And here's what we found, that if we register this data with the image findings, what we see is that the electrogram data points, bipolar voltage, unipolar voltage, duration, deflections, are all associated with left ventricular wall thickness. And I want to highlight this first, because we don't really think about it, right? We think about, we're looking at an electrogram, and it must tell us about whether there is scar there or not. And it's true, the electrogram can tell some information about whether there is scar there or not. But what's important is that left ventricular hypertrophy behind or in front of that scar will hide the scar, because you're going to get more voltage from more hypertrophy. And this is exceedingly common in patients with an area of scar, because the remodeling process is, of course, accentuated hypertrophy and regional hypertrophy in regions adjacent to and opposite the area of scar. So you have to take hypertrophy into account, and that is one of the biggest pitfalls of just using electrograms. It will hide some of the scar you're looking for, particularly on the edges of the scar, which are most important to us. Post-infarct scar thickness, that's of course associated with all of these parameters. Notice electrogram duration. I firmly believe that a lot of the electrogram delay that we talk about these days is electrogram duration, depending on where you take the measurement from, right? If you have a very long electrogram duration and you annotate the electrogram late, then you're going to get a lot of electrogram delay. And so electrogram duration is a very important finding, which I wish our maps would actually easily show us when we're doing catheter mapping. The scar location can have some associations. I'm going to skip over it because they tend to be not so dramatically important. But intramural location, where within the wall it is, endocardial midwall transmural, is of course very, very important. These are all ischemic cardiomyopathy patients. You might say, well, why do they have midwall? They do. Ischemic cardiomyopathy patients can have midwall scar, especially on the edges of the scar, edges of the infarct, where the infarct often, particularly in the septum, can kind of dive into the midwall. It's not like non-ischemic cardiomyopathy where it'll be an extensive region of midwall scar, but on the edges of the scar, they can have midwall scar regions that can be missed with mapping. And electrogram duration, interestingly, and it actually made me feel better about our analysis, the power of the analysis, that electrogram duration is very strongly associated with amiodarone and sotalol, which will again take me to the point of ILAM mapping, or electrogram isochronal crowding mapping that we look at. Recognize that it's going to be very, very much affected by antiarrhythmic drug use, right? Because slowing of conduction will occur by antiarrhythmic drug use. And I think further studies are needed to see how that affects the isochronal crowding activation maps that we see. Now, early on,
I'm sorry to interrupt you for a quick second. I think the audience is having trouble seeing the slides because I think the mode that you have it on, maybe something about the ratio, or is it in a full display mode?
I'm sorry about that. Let's see. Does that make it better or no? It might be because my screen size is so big, but
Gotcha.
Let's see.
Well, I'm sorry. I mean, I just feel like a few audience members were unable to see it well.
Yeah. No, I feel bad about that. Can everyone see this reasonably well?
Yeah, this looks good to me.
Okay, good. So now this is early on. We took some of the images and tried to predict based on the images the electrogram maps that we could create. And this is years ago. We could create the maps reasonably well, and the reviewers asked us to look at these small areas to compare them to see if we could reliably what were the diagnostic indices for predicting these maps. And I want to actually point out that the maps that you can create from images have a lot more information, right? These have information for the full 360-degree view with tons of voxels, if you actually count the voxels of information that are available. And even with our current high density mapping, the maps will not be as dense and information filled as these images. So they can be quite useful, and they actually match information obtained actively in the lab quite well. Now let's look at this scar. I think this is very interesting. This sort of follows well John's talk. We wanted to look at anatomy of circuit sites, meaning if we take this entrainment information here, I have on the y-axis stimulus to QRS divided by the VT cycle length, and then on the x-axis, in a group of ischemic cardiomyopathy patients, this was about 25 ischemic cardiomyopathy patients, the scar transmurality. Now, these are only taken from sites with concealed entrainment. This isn't just entrainment everywhere. So you have concealed entrainment, and we're looking for stimulus to QRS over VT cycle length as a surrogate of where within the circuit we are to scar transmurality on the x-axis. And what's interesting is that all the exit sites, if you take less than 30% as your number, all the exit sites are in greater than 25% wall transmural scar. So they're sort of on the edges of the scar. But what we really love, of course, all of us, is the central pathway sites, 30 to 70%. stem to QRS divided by VT cycle length. And you can see that these are all of them over 75% scar transmurality. And notice that a lot of them were right on the 100% scar transmurality. So this was done when our imaging resolution wasn't perfect. It was, you still get 2D images often. And you might say, well, in the early days, we would look at that and say, well, that's a dense core. There's going to be nothing in there. But actually, that's where all the action was for these central pathway sites. Focusing, I think, on these regions with higher transmurality is extremely important, particularly when we are going after a substrate modification approach. Now, here's an example of one of these 2D images without perfect resolution, where what I've done is segmented the ICD lead. I used to use this for registration. I don't do that anymore. The myocardium, the healthy myocardium, is here in the blue. You can see it's not great resolution, and the transmural scar in gray. And then we put the pen array catheter in this inferior scar, so we're looking from bottom up. And I've marked all the isolated potentials with blue dots, and you can see all these blue dots are spanning the complete transmural scar. And of course, entrainment from here, I can assure you it does capture, John, and gives us a very good stimulus to QRS interval, and we terminate the VT. So if you see 100% transmural scar, it doesn't mean there's no action there. You can find very important areas of the VT within complete transmural scar and MRI, and it's just a matter of resolution, not being able to see it. Now, as resolution has gotten better and better, we can sometimes see these surviving bundles. Here you can see in these three planar images, the red is the complete scar, and then there's these surviving bundles inside it, and you can reconstruct it. You can get, using different software, these nice corridors, and interestingly, they do correspond to diastolic potentials and favorable entrainment sites. But I would want to caution folks that it really depends on the resolution. Just because you don't see something there doesn't mean there's not something there, and it just depends on how good the quality of your MRI was, whether you see that kind of corridor. Now, the new work that we're doing, and I want to thank both Sanjay and Dave Frankel, who are here. They're helping me enroll for this study. We all three of us have enrolled a good number of patients in this, is focusing on fat deposition in ischemic cardiomyopathy. So this was the earliest study that we did in 2015, before actually I came to Penn. Takeshi Sasaki was a really gifted fellow from Japan that worked with me for several years. And we looked at 20 patients with ischemic cardiomyopathy without VT versus with VT. And what we found was that the prevalence of fat deposition, I'm not talking epicardial fat, I'm talking inside the myocardium. You look at it histologically, you see all this fat deposition inside the myocardium was much higher, the prevalence of fat deposition in patients with ischemic cardiomyopathy and VT. So fat metaplasia is an important thing. And we've really been focusing on this lately because of this work by Takeshi, where we found that a lot of the critical sites in that early series were focused in these areas with fat deposition. And in fact, if you looked at the electrogram types, the isolated potentials were all completely within these areas with fat deposition. And that makes sense. Fat is an excellent insulator and will probably provide the right conditions for the protected isthmus of a VT. Now, recognize also that when we get an MR, as I mentioned before, the late gadolinium enhanced areas can be scar, but they can also be fat. Here's an example of a patient that has had an MRI and a CT. And you can see on CT, this black area can be nothing but fat. There's a huge area of fat deposition, and it almost, it's the majority of this late gadolinium enhancement region. And then if we take that image, reconstruct it, bring it to the lab, what we find is that the isolated potentials are all within this area of fat metaplasia, and it's exceedingly important. Now, can we use these images for other things? We can use them to understand the field of view. Elad briefly talked about the field of view of the catheters. And in this work, Satish Misra took some data from our lab. Actually, these are all clinical data, and tried to fit models, basically regression models, and look at the regression model characteristics to understand what anatomic radii best fit the field of view of the catheters. And what he found was that with 1 millimeter electrodes with 4 millimeter inter-electrode spacing, basically panarrays, you see you have a 5 millimeter field of view. And with a standard mapping catheter, single point catheter contact force that we use quite a lot, you have a 15 millimeter field of view. And actually in our data, you could see information about the depth. It does fit with the modeling. So this was very interesting use of imaging to sort of understand the reality of what we're seeing with our catheters. And then you can even get into conduction velocity. So we took data of activation during sinus rhythm in these patients and looked at the association of the local conduction velocity with the attenuation on CT images, and you can see that you can fit a very good regression line if you cluster the data per patient to fit the conduction velocity depending on the attenuation density. So my hope is that in the future, not only will we be able to tell you where is the scar, but we can also tell you where the slowest conduction regions are, which is of course one of the important issues about fixed reentry. So briefly, let me go through some data about non-ischemic cardiomyopathy. Now that data previous to this was all ischemic cardiomyopathy. Non-ischemic cardiomyopathy, of course, gives us the challenge of all these different scar types, and that's really where imaging can be very useful because these can be hard to localize when you go to the lab and you find all normal bipolar and sometimes even unipolar voltage, and yet the patient has reentrant VT that's not necessarily using the conduction system. So where is the scar? When we look at data from this was a group of again around 25 patients with non-ischemic cardiomyopathy. What you find is that you can have all sorts of scar. Most of the myocardium is, of course, normal. But if you look at the distribution of scar, you can have all sorts of it. Transmural is pretty unlikely. Most of it is not transmural. And one important thing I want to point to is that with non-ischemic cardiomyopathy, a lot of times the assumption is it's going to be septal or lateral. And that is true. Septal and lateral take a big proportion of the scar distribution. But just recognize that anterior and inferior distribution do occur and actually are quite common. So just because it's not ischemic cardiomyopathy, don't focus on looking at the septal and lateral distribution of scar. Now, this I think everyone is familiar with. There is a general association with bipolar and a better association with unipolar voltage because the scar is deep. So unipolar mapping can be very, very helpful. What I want to point out is that electrogram duration is actually probably the best way, in my opinion, to map when you're hunting scar in non-ischemic cardiomyopathy. If you look at a cutoff of 100 milliseconds, it really, based on our data, recognizes regions with any transmurality of scar, no matter what the depth is. So keep in mind that if you see abnormal prolonged electrograms, they are probably in regions of scar, even if the bipolar and unipolar voltage are in your normal categories. Now, if we look at our data, what thresholds would work well for identification of non-ischemic cardiomyopathy scar? Bipolar voltage less than 1.8 would work really well. Unipolar voltage less than 5.6. And let me take a moment to talk about this because when I first came to Penn, Frank pulled me aside and said, 5.6 doesn't work so well. And, and so I went and looked at the data, and the mean endocardial unipolar voltage in areas with epicardial scar based on the Penn data is 5.5 plus or minus 1.7. Actually, that fits our cutoff pretty well, but this was the threshold that they picked. That Frank and his team picked because of the fact that 95% of endocardial unipolar signals in individuals without scar was less than 8.27 millivolts. So that cutoff does work. And when I go back to our data and look at it, I think the reason for it makes good sense. If you use 8.3, which is what most people use, and I use at this point, you'll have much higher sensitivity than if you use 5.6. 5.6 gives you the best AUC because it gives you very high specificity. But if you're trying to sort of hunt for these areas that are going to harbor VT, you want to have high sensitivity. And so recognize that you'll have a lower specificity, but you have very high sensitivity if you use a cutoff of 8.3. Now, electrogram duration, add that to your toolbox, in my opinion. And I wish companies would allow us to very quickly develop electrogram duration maps when we're when we're hunting for VT, because the AUC is 0.87 with excellent sensitivity and specificity, and I think it would be a great adjunct. Now, looking at the anatomy of circuit sites in non-ischemic cardiomyopathy, it's harder, of course, to entrain in these patients because their VTs are often so fast and our data is not as good. I can't give you SQRS over VT cycle length, but I can show you stim to QRS. And these sites with slow conduction mostly are in areas of 100%, which is very rare, as I mentioned before, or the patchy scar that kind of starts from the endocardium and extends all the way to the epicardium. So those regions are important to look at. One thing to note is lava late potentials are more prevalent in non-transmural versus transmural in non-ischemic cardiomyopathy. And your exit site QRS duration is affected by LGE transmurality and intramural location, but not by wall thickness at the impulse origin. This was actually something that went against what was in my mind when we started that study. I thought the wall thickness would significantly affect the exit site QRS duration, particularly on the epicardium, but that is not the case. And the most important thing to point out here is that of all the critical VT sites, about 20% are located to adjacent to regions with lit-gad enhancement, but normal, bipolar, and unipolar voltage. So again, electrogram duration is extremely important. Knowing where the scar is in non-ischemic cardiomyopathy is extremely important, because the bipolar and unipolar voltage will actually mislead you in a lot of these patients. Here's data from our work recently at Penn looking at 29 ischemic cardiomyopathy patients with septal substrates, these really tough VTs, 34 critical VT sites. And I want to just summarize that 88% were in the dense LGE, 3% in the border zone, 9% in healthy tissue. 9% in healthy tissue within 7 millimeters of LGE. So they're still close to the LGE, but they're in healthy tissue. And most of the time, here's the most important thing, you all know this, but I think it's worthwhile emphasizing, that in idiopathic dilated cardiomyopathy, all of these critical VT sites were confined to the basal septum close to the valve. So within 20 millimeters of the aorta and almost 20 millimeters of the mitral valve, that's where we want to be hunting, between the scar and the valves. That's the source of these VTs. Now, quick word about ARBC. Shuangwen worked with me on looking at registration of these epicardial points to the MRs, and we can certainly use standardized intensity measures to sort of map out where what the bipolar and unipolar voltage will look like. And even sort of predict where the late potentials are going to be. And if you're interested in this, we have Z-scores sort of intensity thresholds of how to import these, how to segment the images for your analysis. Why is it important? Why do we care? Because you can go to the epicardium and get the same information. And I did this case, this was an ARBC case I did where I had a pen array in the epicardium, just to make the point that if you know where the important substrates are, you don't necessarily need to go to an epicardium, at least not on the first time. If you know where that substrate is, you can put your pen array here in the epicardium, but burn from the endocardium. This catheter, the ablation catheter, is coming from the endocardium. I'm burning around the scar, and the pen array catheter is there just to show the point that as you burn here and you put your final lesion down here, you will get isolation of that region on the epicardium, just burning from the endocardium. So the success of ablation in ARVC in the epicardium, I believe, is not because we're ablating from the epicardium, it's because we're mapping from the epicardium. And if we know where that scar is, we don't necessarily have to be in the epicardium. So that can be useful for some of these patients. So let me conclude here. Image-based reentrant arrhythmia substrate assessment, I think, is a very promising tool as we sort of approach more and more this concept of precision medicine. CMR image substrates of importance for VT in ischemic cardiomyopathy are areas within and near dense core LGE, particularly surviving corridors and high resolution imaging. And stay tuned for data from our Infinity trial, where I think fat metaplasia will play an important role in identifying the most important sites. And in non-ischemic cardiomyopathy, patchy or fully transmural areas, particularly the ones adjacent to aortic or mitral valves. I'll stop there. Thanks so much for your attention, and thanks again for the invitation.
Thank you, Saman. That was terrific. And there's several questions that have come up in the chat, which I certainly want to address when we go to the panel's discussion. So everybody hang in there. We'll definitely try to address most of your questions when we conclude with our last talk. And this is by my colleague, Dr. David Frankel. Dave is an associate professor of medicine. He's the director of the Penn EP Fellowship Program. He's a dear friend and a colleague now for many years. And Dave is obviously multidimensional in terms of both his clinical expertise and research interests. And they are outcomes research, understanding physiology, and then, of course, really refining our approach to VT ablation. And that's where he has done some original work to try to sort out what really ought to be an optimal endpoint for VT ablation. And some of the work that he has done has really changed our practices at Penn and has helped us improve our outcomes. And so I'm very grateful that Dave is here to talk to us about that. And he has actually been invited to participate in an ongoing symposium that's happening right now that Dr. Pristowski is running. And he declined to participate in the first hour of that symposium, so he could be here with us. So thank you for doing that, Dave, and look forward to your talk.
Thanks so much, Sanjay, for the very kind introduction, the opportunity to be part of this. You forgot to mention that we're bitter opponents on the tennis court, but everything else was an accurate representation. So my talk is going to be optimizing endpoints of VT ablation. So I think it's good to clean up after those first three fantastic talks focusing on mapping strategies, imaging strategies, entrainment. So the topic here is, when are you finished? Here are my relevant conflicts of interest. And so, I would say that we all are aware of the traditional endpoints of VT ablation, which target VTs. They include terminating VT during ablation and achieving non-inducibility at the end of ablation. And these are certainly necessary endpoints. So for example, this is a meta-analysis that Frank Bogan put together of post-infarction VT, looking at 6 studies, showing that if you remained inducible for clinical VT at the end of the procedure, it was not good. So if you were able to achieve total non-inducibility, you reduced the risk of having a VT recurrence and long-term follow-up by about 90% compared to if the clinical VT remained inducible. And similar, but to a lesser extent, if you achieve total non-inducibility, you reduce the risk of a long-term VT recurrence by about 3/4 compared to partial success, meaning non-clinical VT remained inducible. So it's clear that you need to achieve non-inducibility. However, we also know from other published data that even when you achieve non-inducibility at the end of ablation, somewhere between 11 to 37% of patients go on to recur. And in the Thermocool VT trial, among the total group of patients who had a recurrence in follow-up, 46% of them had actually been non-inducible at the end of the procedure. Okay, so this in no means is to suggest that non-inducibility is not important. It is necessary, but it's not sufficient as a standalone endpoint. And so as a supplement to non-inducibility, we have a whole bunch of additional endpoints, and many leading centers have their preferred strategies, but the gist is target the substrate, not just the VTs. And we're going to talk briefly about each of these substrate ablation strategies, and then I'll conclude talking about 2 that we are fond of at Penn. So scar homogenization, this is put forth by Andrea Natali and his colleagues, and this is pretty simple. So the advantage, you don't need to do a lot of mapping. You just ablate all of the red stuff. So anything that is less than 1.5 millivolts, bipolar voltage on the endocardium, less than 1 millivolt on the epicardium, just ablate it. And I want to point out, as Andrea Natale always points out himself, each of these red tags on the cardo map is not a minute-long lesion. So the mapper may have given multiple tags per lesion. But the idea is don't waste your time mapping, just ablate all of the scar. And compared to the group that had a limited substrate ablation, the group with endocardial, epicardial homogenization had better long-term VT-free survival. The Bordeaux group, led by Pierre Jat in this paper, like to target LAVA, so local abnormal ventricular activities. You can see a whole bunch of examples here. We have fractionation. Here we have a late potential occurring after the end of the QRS complex. Sometimes you can bring these out better by pacing or giving extra stimuli. And so this is a little more of a targeted way to address the VT substrate. And among the patients, they tried to eliminate LAVA in all of these patients. And when they were successful in entirely abolishing LAVA, the long-term VT recurrence was less than if they could not eliminate all of the LAVA. And this is a mix of ischemics and non-ischemics. I think getting even more refined and sophisticated and more limited in the extent of ablation would be scar dechanneling. So this was put forth by Barroso and the group from Barcelona. And this is a epicardial right ventricular map in ARVC. And what's interesting is you would get these chains of late potentials here, where as you progress along the chain, the degree of lateness gets more and more. So for example, the first potential upon entrance into this chain, the late is just after the far field ventricular electrogram. But then as we move superiorly towards the pulmonic valve, the timing of the late gets later and later still. And their strategy involves ablating the entrances to these conduction chains. And what they report is eliminating entire chains of late potentials with much more limited ablation. So Elad showed this slide before from Rod Tung, looking at ILAM, or isochronal late activation mapping. This is a voltage map here showing basal epicardial scar. And this is a sinus rhythm activation map showing a deceleration zone. So when there is lots of isochronal crowding within a relatively small area, they found that these sites in sinus rhythm tend to correlate to isthmus sites during ventricular tachycardia and represent important ablation sites, addressing the substrate, not specific to any VT. This can be done in sinus rhythm. What we like to do a lot of at Penn is called core isolation, and I'm going to explain why we like this strategy. I think there's two strong selling points. And here's the approach. You make a voltage map, you induce VT. And then we use all the standard tools that Elad and John were describing. If the VT is mappable, entrain. You can give an ablation lesion at an isthmus site or a site of non-propagated extra stimulus. If the VT is not tolerated, which is often the case, then we look for sites at best pace map with long stimulus to QRS, even channels with late potential. So use all the techniques in your toolbox to, as best as you can, localize the critical circuitry for the VTs that you induce. Then you design a core, either a box or circular shape, to incorporate that critical circuitry. You ablate the perimeter of the core, and then you test for entrance and exit block. And I'll show you what that looks like. It's very similar to pulmonary vein isolation. If you have isolated the core, then you induce again. And if there are other VTs, you target those additional VTs, either by expanding the core or focally ablating them, going to a different chamber. And if you haven't yet isolated the core, then you do additional ablation, you do activation mapping to figure out where the gap in your lesion set is. Okay, so this is an example. This is a patient with anteroapical infarction. If you wanted to scar homogenize this, it would take hours of effective RF time. It's a massive scar. Fortunately, this patient had a slow, well-tolerated VT that we could entrain. So here we have concealed fusion. We have a PPI that's just longer than the tachycardia cycle length. So this is an isthmus site. And because it was so well tolerated, we had the luxury of doing extensive entrainment mapping of a broad area of entrances here along the lateral edge of the scar, which funnel into an isthmus and then exit over by the septal aspect of the scar. And so we give a single ablation lesion at the isthmus, a relatively prompt termination. There must have been some width to it, as John was discussing. And then we design our core. So this is a simple case. It's just one tolerated VT, and we know that the circuit is passing like this, okay? So a narrow box that is incorporating that isthmus termination site that you know the circuit is passing through the core. And we ablate the periphery of it, and it's now rendered the inside inexcitable. A very limited focused amount of ablation. So why is this strategy good? So 2 points. Number one, if the circuit passes within your core, then by definition, it also has to exit your core. And that means that even if one of your lines of ablation reconnects, as long as the other line holds up, that VT circuit is still abolished. So it's sort of doubling your chance of durably interrupting the circuit. I'll get to the second selling point next. This is another example of non-ischemic with classic basolateral scar, lots of late potentials. The problem is occurs somewhere between 10 to 15% of cases. No VT can be induced. Not with RV triple extra stimuli, not with LV triple extra stimuli, not with burst pacing on isoproterenol. But this is the substrate. Here are all of the late potentials. So we do a core isolation, needs to be a little more extensive this time. And generally we try and ablate within that dense less than 0.5 millivolt scar. And afterwards exit block is achieved, and both of these patients have done well. Okay, so what does it look like to achieve entrance block and exit block? If you do a fib ablation, then this should all be very familiar. So in this case, which is not what we always do, but in this case, we had a multipolar catheter within the core while we were ablating with the ablation catheter. So at the start of this lesion, you can see that each paced QRS complex, this is a patient with BIV pacing, is entering the core. And then once the lesion set is completed, you now have entrance block, and those paced QRS complexes can no longer enter the core. And I think a better endpoint even is exit block, because this doesn't require the two catheters. So what we're doing in this case is we're again pacing from the multipolar catheter, we're capturing the core. So we're capturing that chunk of ventricular tissue, but there's no exit to the ventricle. So exact same concept as pulmonary vein isolation. And so this, I think, is the other strength of core isolation. It's a physiologic endpoint. You didn't just put red dots on the red substrate, you actually achieve something that you can document and test. And in our experience, when core isolation is achieved, it improves outcomes compared to when core isolation can't be achieved. And specifically, I want to focus your attention on this group, that even among patients who you achieve non-inducibility, if you can achieve the secondary endpoint of isolating the core, the VT-free survival is 90%, whereas if you achieve non-inducibility but can't isolate the core, the long-term VT-free survival is only 67%. So again, meeting that demand for an endpoint beyond non-inducibility that can really be more of a guarantee of success. And then the other one that we do a lot of at Penn is NIPS, or non-invasive program stimulation. And admittedly, this isn't a substrate-based ablation strategy. This is looking at longitudinal non-inducibility of VT. And so what's the point? Why do you need to do NIPS if you did program stimulation at the end of ablation? Isn't program stim, program stim? And so here are some reasons why NIPS may provide supplemental value. So first of all, we've all encountered many inpatients who are non-inducible at the start of ablation. So what does it mean to achieve non-inducibility at the end of ablation? It means nothing. Number two, and I think this is a very important one, is that oftentimes antiarrhythmic drugs are continued right up until the minute of ablation, and it can take time for drugs to wash out, particularly amiodarone, and it may be that a couple days later, repeating the program stimulation, you can now induce some stuff that you could not during the ablation. We know that induction of reentrant arrhythmias is probabilistic, so the more you stimulate, the more likely you are to induce. General anesthesia, that's a big one. So if you're doing an epicardial non-ischemic ablation and you're non-inducible under GA, does that mean you're going to be non-inducible 2 days later under conscious sedation? And the answer may be no, right? General anesthesia is a treatment for VT storm, so we know that it has antiarrhythmic effects. Number 5, ablation lesions can expand or regress. So this is the equivalent. You do an accessory pathway ablation, the patient leaves the lab without pre-excitation, and then the next morning you get an EKG, and unfortunately pre-excitation is back. So a similar concept could occur. You ablate the isthmus, but you just stun those cells, you don't permanently kill them. And another one that we commonly encounter, long ablation procedure, many hours, maybe the patient just isn't stable enough. They're 2 liters positive at that point, and you don't want to subject them to rigorous program stim. So for all those reasons, we like to give patients a day or 2 of rest and then bring them back for NIPS, which we do under conscious sedation. We use the defibrillator, pacing from the right ventricular lead, giving single, double, and triple ventricular extra stimuli at 600 and 400 drivetrains. So just the same way that we do program stim in the lab. If your patient doesn't have an ICD, then you can do this with a quadrupolar catheter placed from the femoral vein. And so these were 200 of the early patients that we did NIPS in, and 11 of those patients with program stimulation at the end of ablation had clinical VT inducible. So there's absolutely no need to NIPS those patients. You know they're going to recur. They need more ablation. While they were waiting back on the hospital floor before NIPS was performed, another 11 patients had spontaneous VT recurrence. Again, absolutely no need to do NIPS for those patients. They're at high risk for recurrence and need more treatment. But among the remaining patients, we did NIPS in 132 of them, and you can see some of the reasons why we didn't NIPS everyone. Most commonly, their heart failure was decompensated. They had acute kidney injury. Sometimes the physician or the patient just didn't want to do it. But among these 132, we induced clinical VT in 24. So we identified 24 additional very high-risk patients for recurrence based on doing the NIPS. And so you may be curious, well, what happened with the program stimulation at the end of ablation with those 24? And the answer is 6 of them never underwent program stim at the end of ablation. 6 of them you could only induce non-clinical VT, and 12 of them were entirely non-inducible. So arguing for the value of more program stimulation. And as you'd expect, if you induce clinical VT, whether it's at the end of the ablation or at NIPS, the 1-year VT recurrence is very high. It's about 80%. If you don't induce any VT, at NIPS, then the 1-year VT-free survival is very good. And if you induce non-clinical VT, it's somewhere intermediate. About 35% of patients will recur in the following year. There's this concept out there that people have that program stimulation works very well in ischemic VT, but not as well for non-ischemic VT. That is not our experience. So the predictive power of NIPS is equally good among patients with non-ischemic VT. So in conclusion, non-inducibility of VT at the end of ablation is necessary, but not sufficient. We need additional endpoints beyond non-inducibility to optimize long-term VT-free survival. Most of those endpoints address the VT substrate directly in sinus rhythm, or NIPS, which addresses VT inducibility over time.
So Dave, thank you very much for that wonderful talk. I know you have to leave this forum soon, so why don't I, start with some questions for you so that you don't you can take off. There are a couple of questions that came up in the chat, and one of them is the example that you showed and how you identified the dimensions of the core. I guess the question pertains to how do you decide how big is the core and how do you, so what is your approach for that?
Yeah, so it's going to vary on the case. And of course, that's a beautiful one slow VT that no matter what strategy you use, you're highly likely to be successful in that case. But I think a much more common scenario is you induce 6 VTs exiting at various locations. And so the core is going to be tailored. It's going to be as small as possible to incorporate the critical circuitry for the VTs you induce. So, if you induce 1 million VTs exiting all over the place, you may need to try and isolate that entire scar, which even that I would argue is probably more efficient than homogenizing. If you do good lesions along the perimeter and isolate, you should be able to achieve the same effect. So, you're tailoring the size of the core to be as small as possible while still reliably incorporating all of the critical VT circuitry that you define by our traditional mapping techniques.
And then I guess the examples that you showed us were pretty well-defined scars, probably both were ischemics. I think one of them was for sure. Do you find it challenging to kind of use the strategy in non-ischemics?
Yeah, absolutely. So I think this strategy is going to work best with dense scar, because the idea is you need to penetrate from the surface you're ablating, whether that's the endocardium or the epicardium, you need to penetrate down to a fixed barrier. So in other words, for an ischemic, if you have some subendocardial scar and you can penetrate down to that subendocardial scar, then you've now isolated all of the tissue endocardial to that barrier. And the same would apply on the epicardium. If you have mid-myocardial or subepicardial scar, you need to reach down to that fixed scar in order to isolate the epicardial component. This strategy wouldn't work well in healthy myocardium or just unipolar abnormal myocardium, because you're not really going to be able to achieve transmural lesions through 1.1 centimeters of ventricle. So your point is very well taken. This tends to work best with dense scar, which is subendocardial, subepicardial. And I think doing this in a septal non-ischemic VT who doesn't have any bipolar scar is probably not going to be as successful.
Great. One last question about the medications. Do you do any modifications for before the NIPS in terms of holding drugs or anything like that?
Right. So we like to, I would say, almost uniformly hold all antiarrhythmic drugs. And you know, the practice has evolved over time, but the current practice is if you induce clinical VT, you go back and ablate that patient again. And we've published now, Daniel Muser, a research fellow from Italy, published with us that when you reablate based on inducing clinical VT at NIPS, you improve long-term outcomes. So it's not just a marker that you're going to do bad, but an opportunity to get it right, ablate more, get rid of the clinical VT, and patients do better. When you induce non-clinical VT, most commonly, we're then going to discharge that patient on an antiarrhythmic drug, either what they were on, maybe you switch amiodarone to sotalol, maybe you decrease 400 milligrams of amiodarone to 200 milligrams of amiodarone, but typically we're going to discharge on an antiarrhythmic drug. And if you're non-inducible, then our common practice would be to discharge on no antiarrhythmic drug, unless there's a separate indication like atrial fibrillation.
Terrific. That was terrific, Dave. Thank you so much for staying on for this long, and hopefully you'll be able to join the other talk without holding them up too much. But it's my pleasure now to bring on board my co-chairs, Dr. Ajit Thachil and Dr. Padmanabhan, who will help me do the panel discussion. I hope the faculty are still willing to stay for another few minutes. I know we are getting close to 11:30 Eastern Standard Time, but if it's all right, we'll just do this for another 15-20 minutes. It would be a shame for the audience to have their questions remain unanswered. I know they're really, really keen to pick on your insights on this. So go ahead, Deepak, Ajit, if you want to field some of these questions that have come through for our panel.
Ajit, why don't Go ahead.
Well, actually, yeah, go ahead, Ajit.
Okay. Yeah. So when we are using programmed extra stimulation, like in the deep strategy, to bring out the potentials, especially based on that first talk from Elad, does it really make a difference which site you do the programmed extra stimulation from, whether you do it from RV or LV or both RV and LV, one extra or two extra? And that's one. And two is, how late should you delay it before you decide that you're going to ablate it? And if you delay it by 20 milliseconds, do you ablate it, or do you ablate only the ones which you delay by 50 milliseconds, 100 milliseconds?
You're muted, Elad, I think.
I know that's the common theme now with the Zoom meetings, like you have to unmute yourself. So these are excellent questions. Unfortunately, I don't have the answer, but I can share with you my rationale. What do you, Nanta Kumar from Canada published about the deep algorithm. He was the original person, I think at least recently, that have published about what's the utility of ablating only those potentials that they have decremental conduction with extra stimulation for suppressing VT, and he showed good data, although limited number of patients. So, I think we've done it systematically, both in animals and in humans. And I think what you find is kind of like, it's hard to interpret, right? Because you are going to get delay, inherently you're going to get delay when you put an extra stimulation. The question is where the delay is. So if you are looking on this manually, you're not using the mapping system, so you're measuring the delay, not between the stimulation to where the electrogram came back, but between the two potentials, because you're going to have like the local, like the far field around where the catheter is, and then a second potential. So most of the places you're going to have decrement in both. So the relationship between the first and the second is not going to be altered. If you do ablate, or if you do find those areas when you have decremental conduction only in this local electrogram, many times it does associate with, or it is co-localized to an area of an isthmus where you do have like a functional block. Now, those areas, if you ablate them, they are fewer than the entire area that you're going to get decrement, and you're going to get the most like bang for the buck. The second question is how fast do you, or what is your coupling interval and what direction? So I think what direction that makes sense. And I'll give you an example. When you want to, look for double potentials on the CTI, you're not going to put like an extra stimulation on 12 o'clock on a tricuspid annulus. You're not going to find anything. It's going to arrive at the same time. So you need to be in an area where you're going to accentuate this difference. You're going to, pace from one side of the line and record on the other side. So you want to pace. So if you have like a septal infarction, let's say, you don't want to pace from the lateral LV. It's better. It makes more sense to pace from the RV. Pacing from the atria doesn't make a lot of sense because you are going to just get decrement in the AV node, not necessarily in the myocardium. How fast do you pace? We typically bring the extra stimulation 30 milliseconds more than VERP. I hope that answered the question.
There's another question regarding the wavefront for determination of scar. I would like anybody of the panelists to discuss about it. I mean, there is recent data to suggest that you have atrial pacing to figure out what scar is versus pacing from the right ventricle to figure out what scar is, pacing from the left ventricle. So Dr. Yash actually wants to actually elaborate on that point, saying that sinus rhythm mapping should be actually replaced by atrial pacing closer to VT rates. Taking it a step further, maybe pacing at the VT rate from a ventricle itself. What's the thought on the panel on that? Would that bring out more scar, more decremental areas?
I'm sorry, I missed the last sentence.
Would that bring out more scar areas? Would that push out signals to so-called become late, as we call them?
If you pace faster?
Yeah, pace faster within the ventricle to create your map as your baseline pacing rates.
Right. So I think, there are limitations too. There is a feasibility of what you can do to what you cannot do. To pace faster, there is a hemodynamic price for this many times. You can do it for a long time. For this reason, I do like the extra stimulation, as John was showing too, because I think with extra stimulation, the patients can be in their whatever rhythm they are in, that they feel more stable, and then you can just interpret at a time one extra stimulation. I think the rapid pacing, like for long duration, is not a good thing. So I kind of stopped doing this because patients don't really tolerate it. But also, you don't forget, you don't have to map the entire chamber. You remember, the days when I was a fellow and Sanjay was sitting in the control room, and he let me practice and map the chamber, and we would take our time and we'll make a 1 hour of a map. Now, if what you want to do is find those specific areas, those specific areas are going to be in a relatively limited location. So identify where the focus is, and then you can bring one extra stimulation. If you want to pace fast, pace fast for a few bits. Focus on the region you want to try to kind of increase the specificity of the already identified region. Does this make sense?
John, do you have any thoughts on the utility of differential pacing and all these things to enhance? And then maybe Saman, your thoughts on this versus how the map or the scar looks versus what the LG enhancement shows.
I agree with what Elad has said. I think in some instances, for instance, inferior infarctions where there's this somewhat preserved annular isthmus of muscle around which the VT can rotate. In the prototypic case, a left bundle tachycardia exits towards the septum, rotating, from there around to the apex, so then around to the lateral wall, and then back through that isthmus. And a right bundle tachycardia goes in the opposite direction, exiting to the LV free wall first. And if you are dealing with one of those and you decide, okay, I'm going to try to maximize my slowing, you can pace on either side of the isthmus and try to bring out some additional slowing or delayed electrograms, late potentials that might not be evident in sinus rhythm. But quite often back there they are anyway. And it's just not, you don't need additional information from that respect. I think if you can get catheters on opposite sides of the septum, or if you're doing epicardial mapping catheters on exactly on opposite sides, that can also help in saying that, yeah, we've got transmural conduction delay. You all, Frank, and you all have shown from the work at Penn that if you have 40 milliseconds delay or so across the septum, exactly opposite each other, that you likely have some scar in there.
Saman, your thoughts on LG abnormalities and how differential pacing enhances the correlation with the electroanatomically defined scar?
Yeah, I honestly, I think that the overall differences in the extent of scar that you see are not dramatic. What I find an important difference in is in finding isolated potentials, abnormal potentials. And so for that, each edge of the scar, I try to pace as far away as possible from it. So, if I'm mapping a lateral LV scar, I find RV pacing usually to be more helpful in terms of seeing the isolated potentials, as opposed to, if it's a patient with a biventricular pacemaker and there's an LV lead pacing right in the middle of that scar, you don't see much of those delayed potentials. So I tend to turn that bi-V pacer off and map during RV pacing or during sinus in those cases. So I think, and in a large scar, you may have to pace from different locations depending on which edge of it you're trying to map, because you just want to be as far away from it as possible. I find it more useful for finding these abnormal potentials than actually delineating where the scar is. I think that there are certainly differences, but they're not dramatic.
Saman, if I could just stay with you in terms of using the technology and the combination of CT together with MRI to define channels, and then the channels potentially the goal is to target them. The same question comes up with substrate mapping to late potentials, and you target them. And so one of the things that I personally worry about, and I think Dr. Lokhandwala raised this point too, do all of these strategies identify for us things that may not be functionally relevant, and you end up ablating more in the process? Obviously, if you're not careful with where the dense scar is, you can ablate on the border zone and hurt an already weak ventricle. I also worry about ablating and causing the kind of scar which can be pro-arrhythmogenic, especially if the channel is just an artificial channel that has been identified. So love to hear your thoughts, and then also John and Elad, if you can weigh in your thoughts about this.
Yeah, I think those are very important comments. I think that in the ideal case, where you have a slow hemodynamically tolerated VT and a distinct ischemic scar, all of us would go with entrainment and the maneuvers that John beautifully showed, and really hang our hat on those and ablate the minimal amount of area that you want to. That's by far and away the best methodology. I think it's been shown over and over again. I think that where these adjunct, and I really consider imaging as an adjunct to what we do in the AP lab, the entrainment maneuvers that we've been taught. These adjunct sets of information from imaging are helpful when you're scratching your head because of the case that's hemodynamically unstable and doesn't allow you to map, because of the case that has 14 different VTs inducible. And you can't even find a good pace map morphology match to what you're trying to target. I think that those are the situations where you want to take this information. And even then, I would not take the entire scar area and ablate it. I think that the situations where we end up doing that, we've all found that it's just not as good a result, even acutely. You tend to have more VTs inducible because they're the sickest patients with the most VTs. But also, I think your point is well taken that you end up in the long term potentially causing more heart failure for that patient and a tougher recovery. So, these are adjuncts, and I think you have to fuse them with our other important methodology that we've been taught, and always remember that there's some tissue that may be better off spared.
John?
I absolutely agree. I've never been a big fan of major homogenization. I think that, and in fact, if you look at the figures from the VISTA trial, I'm fond of showing these to Dr. Natali. It's kind of hard to tell the substrate ablation from the one that was based on entrainment, because they're all red. The whole thing is red. And so I agree that there are going to be areas, especially at the periphery, that are reasonably working myocardium that you don't want to get rid of. And there's a conduction system to deal with, papillary muscles and so forth. And I think in a lot of these people, less is more.
Elad, your thoughts?
Can I just share something? Second, if you don't mind.
Yeah.
I think my thoughts would be better. Do you see actually anything or no?
Yeah, we do.
Yeah.
You can put it in presentation mode. If you can just make it a little bigger.
So you see this map now?
Yep.
So here, I'll give you my thoughts, and my thoughts in general about, the big substrate ablations, either core isolation, whatever you want to call it, if it's not in the operating room. So this is like a septal scar, okay? The top there is just lack of contact, but this is the scar. Now, this is how really, that's from Ruthfeld, this is how it's truly look like, right? Like if you are going to dissect this area. So the border zone that we're looking on kind of like a two-dimensional view looks okay. We can just make some red dots around this thing and capture in the middle and whatever. But this is what it looks like. So the border zone is actually here. It's maybe here. It may be here. It may be here. Now, this map was done with gold standard. There's no better resolution catheter. It's not going to be for a long time. This is what we can get. With this catheter, you get a millimeter or two, information. So what do you really know about this substrate that you really want to so aggressively target? So I am supportive of limited ablation. I definitely see a pro-arrhythmic effect. Sorry, I made this sound for one of the debates with Andrea. Now, the other thing I want to tell you is that, all the time I do a lot of catheter evaluations and all that stuff, but, this is how we measure lesions. We take a swine ventricle or thigh muscle preparation, whatever it is. We apply time and power and we measure this. And very well demarcated, there's very different histological stages of how a lesion is being created and what's the border zone of necrosis. Now, we've done the same thing on scar, and I gave it to one of my colleagues, Jeff Safit, is well-known pathologist. And I told him, we applied ablation 50 watts for minutes in this relatively small scar. Can you tell me where the ablation was done? And he was sure that I gave him the wrong preparation. He was sure that I gave him the wrong heart. So if you really think that all these dots that Andrea is showing there, I just came back from Andrea. I just flew with him back from Europe last night. So, I like him very much, but it doesn't mean that we have to agree with everyone that we like. And I do not agree with this because I really think you don't make any lesions. Now, there are really reasons why you don't make lesions. I don't want to get into this. But this slide I wanted to show, and that was following what John was saying, and I think that and to address also the question about how to pace. In an ideal world, and that's what I'm working on now, is that we will have some kind of a grid that we can just place. And when you're going to a discotheque, everything is going to be I don't go to a discotheque for 30 years, I can't even dance, but if I could. You can pace each one of them separately automatically. And you can reduce the artifact. You can apply a negative current to basically desaturate the rest. So you can stimulate each one of them and measure from the rest. The only thing, John, I don't have here is the cooling part. I think the cooling part is actually pretty cool. But what you will be able to see is that you will be able to see the degree of anisotropic conduction there. And you will see in each area that you are, so you can live it, the software will do whatever it needs to do. And at the end, you'll know exactly where are the areas that are more likely to block versus where they're not likely to block. And this is basically, again, there's nothing new. Maybe we can do it with this technology, but this is all coming from medicine SPAC stuff, from the 80s. But I think that's kind of where the future of this is. At least I hope that that's what the industry will do with this. Yeah.
That's very helpful, Elad. thanks for also sharing with us your past. That explains a few things about you, your disco days. Uh, and hopefully both you and Andre are COVID tested since you took the flight back. So I don't know if
Four
you
times
wanted
in
to.
24 hours. 4 times in 24 hours. It's impossible to
Okay.
fly with.
No, but thank you. That was very insightful. So I guess since we are on the topic, I do have not reservations, but to me, when you have high grid or high density mapping, some of the interpretation, or if not all of the interpretation, is left to the system. There's an algorithm that the system uses to kind of come up with what is displayed. And I guess operator control is minimal or not at all. And how do you kind of, trust the information that you're seeing? Can you?
Okay, so you know that I'll be very, very blunt and honest. So I'll just give you the honest opinion.
Yes.
When you do the studies with the velocity system, it's kind of like, tell me what picture you want to get, I'll give you the result. That's, I think, what happens. It's like PVI, what do you have a gap here? You don't have a gap here anymore. Yeah, you remember those days, right?
I don't.
Because you didn't do it, but some of your colleagues did work with St. Jude a long time now, right?
Okay.
So I think I do work with them, on the algorithms I'm trying to say, but it's a lot of work there because the R&D is really falling behind. And I think, I think it's a problem because, what they do and a lot of the beautiful map that Roth shows, and I think it's their quality work because I think he looks over these maps. But what they do, to Saman's point, is that, what is really important is the length of this electrogram. And what they do, they look backward. So they go from the end of the window and scan backward. And the last electrogram they see, they annotate. Most times, 90% of the time, it's noise because they have no ability to separate noise from electrogram. And we have to do it in our eyes. So to your point, what is better? High resolution, high density map, or low resolution or low density that is accurate. Low density is accurate is good enough. Now that's one extreme. The arrhythmia, on the other hand, very hard to work with. They don't have a very good ablation catheter, but at the same time, the algorithm and the mapping catheter itself are excellent. So the amount of annotations or re-annotations you need to do is minimal. Now, obviously, there are going to be areas of confusion because, you see those double potentials, and what is far field, what is near field is not really easy to determine. Not only that, think about it that many times, dV to dt of the unipolar is being, many times it's not only determined by this, small little surviving myocardium because most times you're not just right on it. So it's going to be determined by the mass of tissue. So a big mass of tissue can generate a steeper dV to dt than but overall it's very accurate. So you don't have to do much annotation. With cardio, it's kind of somewhere like in between. You'll have to do a lot of annotation, but there's no easy way around it because really there is a physiological problem there. You do have multi-components there. Even if you and I look at them, we may not agree of which one is the local, which one is not the local. Sometimes you just have to pace. So I think it's a challenging problem.
One thing that bothers me a lot is the endocardial architecture. If you've got a big aneurysm, it's smooth. Most of the architecture, the trabeculations are gone, they're all flattened. And you can lay a grid electrode or a pentaray or octopolar on those and be free of noise, largely, unless there's electrode bang, but also pretty good contact throughout. If you've got a highly trabeculated piece of muscle like Elad showed on that cross section, good luck in getting contact everywhere. And all the time around the valves we're seeing weird stuff, these crazy deflections that can't be physiologic. They look pretty good. They look like an electrogram, small electrogram, but I've been fooled a number of times chasing these things around above the aortic valve, around the mitral valve, even the tricuspid valve. We see these. If you look at the next 10 cases you have of SVT and look after the ventricular electrogram on the His recording, there's stuff there. I don't know what that is. I think it's just reverberation off the valve or what it is. But if we see something like that, an electrogram, what looks like an electrogram in a piece of muscle that we think, oh, that's scar tissue, or a right bundle left axis VT, oh, that's a delayed Purkinje thing, we're all excited about it. But when we see it after a His potential in somebody who has no reason to have it there, it's artifact. So we need to be a little bit more, I guess, honest with ourselves about what is a real signal and what is not. And I'm not sure these systems, the annotation systems, are up to the challenge there. I think the cross correlation that arrhythmia has several different criteria that surrounding electrogram, surrounding electrodes have to see it, so it's not just an offset artifact or something like that. But I think Sanjay, you're right on with let's trust technology only so far as we can and not infinitely. One of the points I wanted to make early on in my talk was that I'm troubled by the tendency amongst our fellows and what's being told to them in conferences and in the literature, that when you see the entire circuit, the entire cycle length of a tachycardia represented in a map, it's reentry, and you've got the circuit. And I'm working on a series where that is just exactly wrong. In fact, 180 degrees wrong in some cases. And I had a case the other day where we had a left atrial perimitral reentry. We had 4,000 points in the left atrium, but we didn't have the cycle length covered. We did in the right atrium, where there'd been a CTI line before. So I think trusting technology is only so far as you can, and is a very good principle.
Well, it's the reliant on technology by the fellows that is like, I don't know, I see today, like everyone talking about microsynthesis, like all this high resolution mapping came along. So there's like micro reentry. All of a sudden, micro reentry became the most common mechanism of arrhythmia, which is absolutely an artifact in most times.
Yeah.
Well, those are some very wise words, and John's sagely advice, together with Elad's, understanding of these systems, to give us some direction on what to trust and what not to trust. And of course, Saman's wonderful analysis of imaging to complement what we know has been just a great session for me. I mean, this is so good, and I'm so grateful for the faculty for really sparing their Saturday morning on a weekend to come and join us. And I hope the audience enjoyed this. For me, there's no better way to start my Saturday than to meet some of my best friends online, and then to think about VT only on Saturday. Sunday, I'll do something else. But thank you again for really taking the time to do this. I want to thank the audience in India for staying up late. I know it's getting close to 10:30 almost. So thank you. Dr. Lokhandwala, if you want to say something to us.
Yeah, well, I know, I think it was an enthralling session. I think the good thing is that, for people like me, it was reinforcement and learning some new things. And for the fellows and the youngsters, who tend to get carried away by pretty pictures, you should also know the nitty-gritty and about being discerning, and also being able to rely on being an electrophysiologist rather than just looking at pictures. And I was also very the imaging talk also was interesting, because yes, we can use all these strategies when the VTs are not mappable to because I myself have been pretty actually worried about this extensive ablations. So I think the talks were very much in sync, and I'm sure all of us who attended gained a lot of points from the insight and wisdom of all the experts who, Sanjay, you convinced to take part in this symposium. So thanks a lot.
Well, what can I say? I mean, these people are my friends, but every once in a while you cash on your chips, and I thought, what better way to do it than to introduce these stalwarts to our colleagues at home. So thank you again. Vanita, do you have anything to add to Yash's?
A huge applause. Just a huge applause. Thank you so much. Thank you so much for doing this. And thank you. That's all I can say. Amazing session. Amazing.
Terrific. So this is wonderful. John, Saman,
thanks
Elad.
so much for having us. Yash, get well soon. I hope you have a good recovery.
Thank you. I
All right.
enjoyed it as well.
Thanks. Elad skipped the disco tonight.